Hello, and welcome to the Health Data Ethics Podcast. I'm your host, Jenny Owens, and in today's episode, we're going to talk about some of the human pushback to using artificial intelligence in the healthcare setting. Specifically, we're going to be talking about nurses. So for decades, nurses have been the backbone of patient care related systems. They give comfort, they make critical decisions in high pressure situations. And now we're starting to see some AI encroaching into the nursing domain. It's promising efficiency, it's promising cost savings, but for a lot of nurses, this is also a threat to their profession, to their patients, and to the moral principles that they uphold, right? That they have the responsibility and the honor to have that direct care and that direct decision making over their patients. So the question that we kind of want to wrestle with today is, will our technology enhance care, or will some of these AI related assistants start replacing people and make our healthcare less human? So we're seeing AI-powered nursing assistants. I'm going to use heavy quotation marks here because I have not seen that these tools really are being used to replace nurses on the floor. We're looking at support and replacement for administrative-related nursing tasks. So like calling patients before surgery to make sure they're prepared with medication and dietary changes. These are often pitched as an attempt to address nursing shortages and burnout. And we've covered on the podcast that nurses and nurses unions are pushing back, raising concerns about patient safety, about the quality of care, and about their job displacement. Will this be used to change our ratios? Will this be used to encourage us to provide a lower standard of care? One of the things that I do want to call out is that when we're using a tool like this, so for example, we're using there's a number of tools out there on the market that will call a patient and walk a patient through, say, pre-surgical instructions. These tools need to adhere to our regular AI ethical and regulatory principles, including they need to be transparent. If I'm having an AI assistant do what a nurse would do and call me before my surgery and walk me through my pre-surgical instructions, it needs to identify itself as an AI tool. It cannot impersonate a nurse on the phone to me. We need to make sure that if we are using AI tools in healthcare like this, that they're working for all populations of patients, right? So there's a recent article in the Associated Press that was gathering a bunch of different perspectives on nursing AI assistants. And Rochelle Fritz of the University of California Davis School of Nursing actually mentioned that AI programs like this may work for people who are relatively healthy and proactive about their care, but for the very sick, people who are taking up the bulk of the healthcare bandwidth in the United States, a chatbot or a phone bot, whether that's going to be really a good use for those folks is something we really have to consider, right? If this is somebody who's maybe not as technologically able, if this is somebody who's not able to receive a text message, if they only have a landline, it's worth thinking about the varying ways in which you reach patient population and what a human can do that a chatbot or a phone bot may not be able to do. We want to make sure that our AI use cases are well developed and that they're not going to perpetuate bias in our system. AI should be used where it excels, right? So repetitive, non-clinical administrative tasks like scheduling, like documentation. A great example of this is Cedars-Sinai. They've been testing an AI mobile application called AIVA Nurse Assistant, AIVA. So the app allows nurses to use a mobile phone to document patient information in real time using dictation, transcribes that data, and then after it gets validated, that information gets filed into the patient's electronic medical record. It takes a little bit of the documentation burden off the nurses. The information is still validated by professionals, so we're not compromising the data, but we are taking a little bit of the documentation burden off of people. It's also helpful to see AI in patient monitoring and alerts where AI can detect early warning signs, but you want to be careful that you're referring those to humans for their human judgment, to nurses and doctors for their medical judgment, and not just automatically triggering action based on an algorithm. Really neat example of this. There's a lot of examples actually of kind of bunkerized monitoring. There's a neat one in Africa, actually. They were doing some AI-enabled fetal monitoring that allowed them to do continuous real-time monitoring of fetal vital signs during labor, which would allow people to immediately respond to complications. Since that was introduced 3 years ago, this center in Malawi has observed an 82% reduction in stillbirths and neonatal deaths. Very cool. So again, AI really excels when it is acting as a safety net and a support to our clinicians and not as a replacement. AI definitely should not be used in situations that call for high complexity or situations that call for high empathy, right? You don't want to use an AI nurse to break bad news. That'd be terrible. There's a lot of AI tools out there that are promising that they can reduce the workload, that they can cut costs, that they can improve efficiency. Just remember that all of that comes with a cost for your IT team. workflow integration, making sure that we've got the correct data feeding in so that we're actually able to use these tools effectively. And you can also face a lot of resistance from your staff, from your nurse, from your doctors, from your clinicians. A lot of these AI systems are really big on demos and somewhat short on long-term benefits. So you want to make sure that we're thinking about, when we're evaluating these tools, does this actually improve patient care and safety? What can we measure to make sure that it does? Does it integrate well into our existing EHR and into our workflows? What is it that we're expecting to see financially as a return on investment? Are we expecting to see, real dollars saved? Are we expecting to free up effort that can be used elsewhere? Or are we expecting to see, more money coming in? Or is this an expensive experiment? And if that's the way you want to play with your money as a health system, like, great. I love that. Can I come work for you? That would be really fun. But I think a lot of times we do expect to see a tangible or a financial benefit that's coming out of these experiments that we're doing with artificial intelligence. In the end, I really feel like AI in medicine is inevitable. We're going to see AI assistants for our doctors. We're going to see AI assistants for our nurses, but it has to be shaped by these populations, right? I want MDs, I want nurses, I want APPs at the table, shaping this technology, not having it imposed on them. And I want to make sure that we're balancing our efficiency with empathy, not only for our patients, but also for our providers, for the people who are hands-on with our patients. I know that it's a cliche to say that medicine is a calling. Even not in a patient care hands-on position, I feel like healthcare is a calling, right? It's really lovely to have a job where I feel like I'm making the world better for people. I think it's really important to not automate that part of it away. A lot of people are doing medicine for reasons that are not purely financial. They're not purely skills-based, right? They do medicine because they love it, and we definitely don't want to replace that. We want to keep our focus on our AI adoption and make sure that our tools serve our caregivers and our patients first before anything else.